Hey guys, welcome to the Ultimate USMLE Thyroid Lecture Part 1. This should be a great resource for your Step 2 CK and Step 3 preparation. So I'm going to just remind you that as a starter, you should really know the symptomatology of your metabolic states. Now what I mean by that is it's the T3 on the target tissue, or the lack of T3 on the target tissue that's causing your hyper or hypo states. And another thing to remember is that sex hormones and steroids are huge effectors. So you can have blood work where there's a certain state that looks like hypothyroidism or hyperthyroidism, and there's no problem with your thyroid or pituitary. So keep that in mind. And remember the classic findings in a hyper state. So in a hyper state, you've got lots of T3 hitting your target tissue, and in a hypo state, you've got a lack of T3 hitting your target tissue. Don't get confused, because a lot of people, they get scared when they see vignettes about the thyroid or thyroid problems because they think FNAC, TSH, FNAC, TSH. So it boils down to two things. If there's only symptoms suggestive of hyper or hypoactive thyroid, you're going to check the TSH and the T3, T4. That's it. So if there's only symptoms suggestive, if that's the only thing that's there in the clinical picture, you're going to go for the TSH. If there's a thyroid nodule, and just forget everything else, look at the thyroid nodule. You're going to check the TSH, but also, in tandem, you're going to have a closer look at the nodule via clinical exam and ultrasound. And you do an FNAC. After doing those three things, only if you have a high clinical suspicion or the TSH is normal or elevated. So why you would do the FNAC if the TSH is normal or elevated is a hyperactive thyroid is rarely malignant. It's rarely malignant. A hypoactive thyroid can be malignant. It can be Hashimoto's, but it could be malignant. There's a fair chance it could be malignant. So you do the FNAC if you have a normal or elevated TSH, or if there's just a high clinical suspicion.
So when we talk about our thyroid states, there's regulation on so many levels, not just one. And in my previous slide, when I stated that when you have a hyper state, that's usually indicative of the action of T3 on your target organs. So T3 and T4. Because remember, T4 is what gets converted to T3 peripherally, but T4 can still have some action on the target tissue. It's just that T3 is the main one. You're going to have an elevation. So this is always true with hyper. However, I want to show you something that our TSH is elevated or decreased depending on where the problem is. So if your thyroid, your actual thyroid gland, is a thing with a problem, what's going to happen is, so it's defective, okay, and it's hyperactive because it's defective. And an example is Graves' disease, where there are thyroid stimulating immunoglobulins which stimulate the thyroid to output lots and lots of T4. So what happens is your T4, and then as a consequence T3 goes up. But the anterior pituitary, which is what releases the TSH to stimulate the thyroid, it will respond to the elevated T3. So then it will decrease the TSH, because it'll say, well, you know, your thyroid is putting out too much hormone. There's too much hormone in the circulation, so let me decrease the TSH, because the thyroid just should not be stimulated. So anytime you see this pattern, there's a primary defect. It tells you that there's a primary defect, meaning the defect is in the thyroid. So it's called primary hyperthyroidism. Now, if you have an adenoma in the pituitary that causes an excess secretion of TSH, it will stimulate the thyroid hormone, which is normal. So you have an abnormal pituitary, but a normal, so let me write this, abnormal pituitary. So there could be a abnormal pituitary and a normal thyroid. So the thyroid is normal, but you got a whole lot of TSH coming out of the anterior pituitary, and that's going to cause the thyroid gland to be hyperactive, and therefore you're going to have lots of T4 and as a consequence T3. And so if you have someone with an increased T3, T4 and an increased TSH, that is secondary hyperthyroidism. And it's usually because of a pituitary adenoma. Now, a hyperthyroid state can be from several causes, so not just Graves. So I'm going to go over that next.
So if you have a primary hyperthyroid state, which remember, as I said, is a elevated T3 or T4 and a decreased TSH, remember that the exophthalmos, periorbital edema, and prominent goiter are specific findings to Graves, but they're not very sensitive. So you could have a Graves disease, you could have those immunoglobulins against the thyrotropin receptor, which is how Graves disease manifests itself, but you don't necessarily have to have the periorbital edema. So if you do, though, have the periorbital edema and obvious goiter, you're done. You know that the hyperthyroid state is because of a Graves disease, and you don't have to go through any more lab work. However, if you don't have such an obvious clinical picture, you want to know whether that hyperactivity is in the thyroid gland for real, or what's going on. So you're going to do an RAIU scan. If the uptake is high on the RAIU scan, you have two basic disorders, Graves or toxic multinodular goiter. So you look at the pattern of the uptake, if it's high. And if it's a diffuse high uptake, it's Graves. If it's more of a nodular pattern, you're thinking toxic multinodular goiter. Now, low uptake is found in three basic conditions. Thyroiditis and definitely mainly subacute thyroiditis, cancer, or exogenous ingestion of hormone. So a lot of people don't necessarily understand the first one. They they may understand exogenous because they know, well, if you're taking hormones like, as weight loss or whatever, there's not going to be any, hyperactivity in the thyroid. It's exogenous. But for subacute thyroiditis, I think, well, if there's a state, abnormal state in the thyroid, there has to be high uptake. Why is there low uptake? And the reason is that subacute thyroiditis is basically a sequelae of having a viral infection or a stress state that causes the cells in the thyroid gland to be so inflamed that they start to empty out the thyroid hormones, the T4. And the T4 goes into the bloodstream, and they have the elevated T3, T4 as a result, and they also have a depressed TSH. So there's nothing that's really hyperactive in the thyroid. There's inflammation, but there's no hyperactivity in the thyroid gland, and that's why there's low uptake. In cancer, the cancerous cells, those are aberrant cells. They don't have the normal function, and that is why they do not have a high uptake. And exogenous, of course, the name says it for itself. Remember, though, in any case, if there is a hyperactive state in the thyroid, it needs to be treated. Before you do that, you need to address life-threatening stuff. And the life-threatening stuff is the irregular rhythm, the palpitations, the manifestations of sympathetic hyperactivity. And that you treat with a non-selective beta blocker, such as propranolol. Now, after you have addressed the sympathetic hyperactivity, you're going to move on to medical management of the hyperthyroidism. And medical management can be effective, but you need to watch out for infections and pregnant states. So what I mean by that is methimazole, which is the first-line drug for treating hyperthyroidism, has an effect on the granulocyte colony of white cells, which causes people who are on methimazole to be prone to infection. So if you see a patient who's being treated for hyperthyroidism and they get, these chronic infections, really think methimazole. And the pregnant state, you know that methimazole is a teratogen, and it should not be taken the first month of pregnancy. The first trimester of pregnancy. So during the first trimester of pregnancy, you're going to substitute propylthiouracil for methimazole. Methimazole can be continued thereafter in the pregnancy. If you have a patient who's refractory to medical therapy or there are compressive symptoms, you need to take a tougher approach. So there are two tougher approaches in the treatment of hyperthyroidism. That's a radioactive iodine ablation or a thyroidectomy. Now, a radioactive thyroid ablation is for people who simply are refractory to medical therapy and where the compressive symptoms are not much. And also where you do not have a severe exophthalmos. If you have a severe exophthalmos, the radioactive iodine ablation can make it worse. So in the case, if you have really bad compressive symptoms or the exophthalmos and periorbital edema are severe, you're going to go for a thyroidectomy. Also remember, you have to avoid radioactive iodine ablation in the pregnant state. And of course, after you have removed the thyroid or done the ablation, you have to replace the thyroid hormone. In the case of secondary hyperthyroidism, of course, you would just proceed with an MRI to confirm it.
So when we talk about hypothyroidism, and I went over what the classical symptoms are, so hypothyroid state, you're going to have a decreased T3, T4, and if the level of the problem is at the thyroid, so you have a thyroid that There are antibodies too, and that's causing some kind of lymphocytic infiltration, which is the most common cause of hypothyroidism in the primary state. The hypothalamal and pituitary axis is intact, and it's going to respond by elevating the TSH. But say the thyroid is normal. So you have a normal thyroid. But there's some aberration in the hypothalamal pituitary axis. And a common cause of that is some kind of hemorrhage. The amount of TSH that's being released by the anterior pituitary is going to be less. And consequently, the thyroid gland is going to respond by releasing less T3, T4. And that's what we call a central hypothyroid state, or secondary hypothyroidism.
So my next video, I will go over more on Hashimoto's pathophysiology, thyroid cancer, pathophysiology, diagnosis and management, and the effect of sex hormones and pregnancy on lab values. So if you want instant notification, please subscribe. It's free and all you need is a Gmail account. Thank you.